right. So this lecture is always a good one to start off with because I think that, one of the first things I think about when I think about internal medicine is also like general internal medicine and primary care. So I think one of the best things to kind of start off with is just thinking about preventive medicine. So we're going to be going through all the evidence-based screening and surveillance guidelines, and I like to use the United States Preventative Services Task Force as a reference because I think it's probably the most validated resource for internists. Have you guys heard of the USPSTF? Some of you have, some of you haven't. I'm sure once you hit family medicine, you'll definitely have heard of it. I don't actually know if I have. So the USPSTF basically is a government-funded organization that puts out guidelines for all screening tools available for internal medicine. And the main thing that they do is that they're an independent review of all of the literature regarding screening. So it's usually like panels of clinicians and epidemiologists, biostatisticians, who will review all the literature, and basically they can't have any sort of bias. So if you're a breast surgeon, for example, you're not going to be coming up with like mammogram recommendations. But you might be on like the colorectal cancer screening recommendations group because of your expertise. And essentially what they'll do is review the evidence and only review the evidence for it. So they don't take cost into consideration. It's all just based on like the efficacy and number needed to treat or screen in order to come up with their recommendations. And they try to keep them as up to date as possible. There's often like recommendations that are kind of in review. And then they'll also kind of give you a grade of their recommendations. So have you heard of like grade like A or 1 or B? So basically, a grade A evidence is strong evidence of a really strong result. B would be either really strong evidence of kind of a moderate result or moderate evidence of a strong result. And then C is just kind of like moderate evidence of a moderate one. D is evidence that the harm exceeds the benefit, and so you shouldn't do it. And then they have I, which is insufficient evidence. We're going to talk a little bit about the Medicare annual physical because when you do your outpatient experience, you're going to learn a lot about that. And I think it focuses on some elements of primary care that we don't often think about but are definitely important. And then we'll be talking about the adult immunization schedule. So all very primary care heavy. So getting into screening, I always like to do a review of screening. You guys probably had some lectures about it last year or the year before on screening tests and no, you guys are a more quiet group than the last one. Maybe it's because I keep catching you in the morning. But basically screening is recommended when it can be beneficial. And so that would be like if it's a serious disease, when the treatment before symptoms occur is more effective than treatment that's delayed until symptoms occur, and when the prevalence of the disease in the general population is relatively high. So, for example, like glioblastoma multiforme is a very serious disease, but we don't have any evidence that there's a screening test that would be able to be widely disseminated into the general population because it is so rare. It's too rare of a disease to be worthwhile to screen for it. And we don't have any evidence that, identifying it early in the course actually has any clinical benefit. On the other hand, like prostate cancer is actually very common and can be very serious and fatal in a lot of populations. But there isn't a lot of evidence to suggest that treatment of early prostate cancer actually leads to clinical benefits. So that's kind of why we have these different criteria. Some additional characteristics of a good screening test are that it's inexpensive or relatively inexpensive or has like a cost benefit. It's easy to administer, so obviously you don't want to go and biopsy every single person's kidneys to screen for chronic kidney disease, right? Causes minimal discomfort. It's reliable and valid. So I did have a slide on the USPSTF. Again, basically their kind of mantra is to provide high quality, methodologically sound, scientifically defensible, reproducible, and unbiased recommendations on primary care services. And like I mentioned, it's experts in fields not associated with their categories, and cost effectiveness is one thing that is not considered. Okay, so getting into cancer screening, that's one thing that I always like to start off with. There's a lot of evidence out there for various cancers, and you always have to look through the lens of the provider as well. So you're definitely going to get a different opinion about screening for prostate cancer, for example, from an internist versus an oncologist or versus a urologist, right? Because everyone's going to kind of have their own biases walking into it. So just to kind of pull you guys, what cancers currently have screening recommendations? Colon cancer, okay. Was that breast? Cervical. Prostate, okay. Okay. Okay, so those are all things that will pop up, and some of them have stronger evidence than others, and some of them have very limited evidence, and there are a few more. So I think the first one we actually have is colorectal cancer screening. You guys might have actually done it in the order. And I'm basically kind of starting off with the ones that have stronger evidence, and then we'll kind of move to the ones that have weaker evidence for them. So the latest recommendation from the USPSTF was in 2016, so it's a little bit out of date, and I think they actually have an update that's in progress. And right now, the recommendation is to screen for colorectal cancer in the general population in patients starting at age 50 and continuing until 75 years. So we actually have grade A evidence, like I mentioned before, that's relatively strong evidence of a strong benefit. So screening for this in this population can actually decrease the rate of colorectal cancer associated death. And then, depending on the patient situation, you can consider doing screening beyond 75 years. So you guys probably know a lot of people who are in their late 70s, early 80s who are thriving, and you can expect to maybe live for the next 10 years or so. So they might be people who you would want to continue to screen. Okay, so some of the options that we have for colorectal cancer screening, what have you guys heard of most commonly? Colonoscopy, far and away. We consider it to be the gold standard because in addition to screening, you can also sometimes even do like therapeutic interventions as well. So like removing a precancerous polyp can actually reduce the risk of progression into colorectal cancer. What else have you heard of? Fecal cold blood, okay. Okay, a CT colonography. Has anyone heard of any other ones like out there? Okay. Yeah, so Cologuard, that's the one that kind of comes up colloquially. So essentially, we have the stool-based screening and then direct visualization. So the stool-based screening, so we have the Guaiac fecal cold blood test, which would need to be done annually if you wanted to choose that as your method of screening. You can do an annual fecal immunohistochemical testing, or you can combine the fecal immunohistochemical testing, or FIT, with some DNA testing that's recently been developed in combination with that, and that's what we consider to be the Cologuard. And that could actually be done every 1 to 3 years, but it does actually have a higher false positive rate. However, every single one of those, if you end up getting a positive test, you're obligated to do kind of like a diagnostic colonoscopy. So it does require a follow-up. But, if you had a patient who, had a lot of medical comorbidities and you didn't necessarily want to administer even mild sedation in order to do a colonoscopy, then it might be worthwhile to consider that. And then you can also do some of these direct visualizations. So colonoscopy, if normal, can be repeated every 10 years. So if you don't get any polyps, or I think like up to 2 polyps, as long as they're small, you can repeat it every 10 years. And then there's also flexible sigmoidoscopy every 5 years, or you can do it every 10 if you do the annual FIT testing. So you can do those in combination with each other. And then CT colonography was definitely something that was super in vogue, like when I was in medical school about 10 years ago now. Oh my God. Basically, they found that it doesn't have sufficient evidence to support its use. It also requires a follow-up colonoscopy if there's any abnormalities. And if there's any issues with the prep, it can look like stool can actually look like a polyp. So I have actually never had a patient get a CT colonography, except for I think once. I think I had a patient who had it before he met me and brought that in. But generally, I think most people will recommend colonoscopy, and then, if the patient doesn't want to do that, then we'll sometimes do like Cologuard is what we will do in practice. But basically, all of these, except for CT colonography, can be done.
Do they have to have a family history of colon cancer to have Cologuard?
No. So it can be done as just regular screening, and even Medicare pays for it now. So a lot of patients that you'll see probably in your outpatient experience or when you're on family medicine will actually have had a Cologuard.
What's the cost difference from doing, say, like the FIT DNA with the FIT and the DNA, and then if it comes back false positive, which says it has a higher rate, than just doing a colonoscopy? Or is that based off what the patient?
I don't know what the cost of a Cologuard is, but I know that for example, like most insurances will pay for preventative services and screening things. So the insurance might pay for the Cologuard, but if that's positive, then they end up getting a colonoscopy, which ends up coming negative. The colonoscopy is actually diagnostic, and the patient has to pay like a nominal fee associated with that, depending on what their insurance is. So if you just do a screening colonoscopy and they identify polyps and take them out, that's all kind of covered as a screening procedure. So cervical cancer screening, it had a fairly recent recommendation in 2018, and basically said there's like 2 different styles of screening for cervical cancer. So what are the 2 things that we think about?
Can you do the PAP or the PAP? Is that what you're talking
Yeah.
about? Or the PAP or the HPV?
Yeah, so PAP and then HPV testing. And so essentially, the general thought process is that PAP smears will screen for abnormal cells, right? And then HPV is really what's kind of associated with the increased risk of cervical cancer. However, a lot of people will be exposed to HPV, though with vaccination, it's a lot better. At an early age and should clear the infection before it becomes problematic. And it's really that persistent infection that we worry about. And so generally what we'll do is starting at age 21, not before, do a PAP smear every 3 years. And you can basically do that until 30 years old. And if you add HPV testing, you can space it out to every 5. And so you could just do like a PAP smear by itself every 3 years for the rest of their lives. But if they're 30 years or older, you can add an HPV co-test and spaced out to every 5 if they are negative. And this is a typo. You only screen till 65 in patients. And this is all just assuming it's normal. You guys probably have already learned about like the follow-up for abnormal PAPs because it can be complicated based on whether it's just ascus or is it ascus with HPV or the other types of abnormalities. And obviously you have to continue for 20 years after they have an abnormal PAP. But This is kind of just like the general screening recommendations. You guys have gone over this ad nauseum, I'm sure. Did you guys do a lot of breast cancer stuff too with OB?
Not really.
Okay, so what do you guys know about breast cancer screening? What options do we have? When do we start? What's that? Mammogram, okay. Ultrasound, okay.
Didn't they stop recommending self-breast exams?
Yeah. So actually, the USPSTF is very, I wouldn't say anti, but like not supporting of self-exam. So like testicular exam, breast exam, and now they've actually said that like doing like a digital prostate exam and doing a clinician breast exam don't have a lot of supporting evidence that they reduce the risk of, or reduce the burden of the associated cancer. That's not to say that you shouldn't do it, but it should definitely not be your primary modality for the screening tests. So breast cancer is a very controversial topic, and it kind of depends on who you ask, because ACOG probably has a different screening recommendation than the USPSTF. But basically, the USPSTF says that starting at age 50, you should start doing mammograms every other year and continue until 74. And then and basically you can maybe continue it after that. But this is only a grade B recommendation. So it's not even as strong as colorectal or cervical cancer screening. And they said that the patient population that actually benefits the most are patients between 60 and 70. And so they say that, and then basically it's also an individual consideration to start earlier at age 40, which is a grade C recommendation. Again, just moderate evidence of a moderate benefit. And so they specifically state that women with a parent, sibling, or child with breast cancer may benefit from earlier screening. Now, I'm sure at least one of you guys knows somebody who is diagnosed with invasive breast cancer earlier than 50 or maybe even earlier than 40. And a lot of people in the general population can say that as well. And so just to kind of give you an idea of how hot this topic is, when the Affordable Care Act passed, one of the elements of that was to say that all preventative services that are USPSTF grade A or B should be covered in like the public exchanges. And then they said, and breast cancer screening from 40 to 50, because no one wanted to touch it with a 10-foot pole. They're like, this is like too controversial, so we'll let that be covered as well. So the evidence is actually strongest screening at older ages, but I think there's a lot of like personal history that that impacts when you might start. Questions about that? Okay, so one thing you guys did not mention actually, and it's actually one of the newer recommendations. So the initial recommendation and the latest update in that was actually in 2014. Was screening for lung cancer. Have you guys heard of this before? Okay, so some of you are shaking your head yes, some no. But basically it has very specific parameters for when you would screen. You would start at age 55 if the patient has smoked 30 pack years. You guys remember how to calculate pack years, right? And they have quit within the past 15 years. So if they're a current smoker or they quit less than 15 years ago, then you'll start doing an annual low-dose chest CT, every year until they turn 80, or until the patient has quit for 15 years. So if they quit 10 years ago, you would basically do it for do the screening for 5 years and then stop. But obviously, like if they have abnormal findings, then you have to continue to evaluate those. I have like personal opinions about this recommendation because the evidence for it I did not find to be as impressive as the USPSTF concluded. Basically, they compared the annual low-dose chest CT screening to chest X-rays, which was never a validated chest or lung cancer screening tool. And so they definitely had a higher benefit than I think was really valid. And there are a lot of incidental findings that you end up getting on these chest CTs. But it is a very low dose amount of radiation. It doesn't require IV contrast, and really is the only way that we can screen for lung cancer at this time. So again, it's a grade B recommendation. It's one of the newer recommendations, and it definitely requires a slight memorization of the 3 criteria that you need to meet. Questions about that? Okay. Okay, so getting into the wonkier evidence, basically prostate cancer screening keeps kind of going between grade C and grade D. Up until 2018, it was a grade D recommendation, which was actually like the harms outweigh the benefits. As of 2018, they said it's a grade C recommendation to start screening with a PSA test between 55 and 70. And they don't even really give specific intervals that you would do. So basically periodic PSAs between 55 and 70. As we know, most patients with prostate cancer die with it rather than from it, because it's a very common cancer, but it's not super common to have invasive disease. So right now, the USPSTF and actually the American Urologic Association are in agreement that it should be an individual consideration. So you talk to the patient about the risks and benefits of screening and kind of the ramifications of a positive test. And then if they choose to do it, then you will. Do you guys know some of the downsides to screening? It's just a blood test, right?
The follow-up core biopsies
Okay,
of the prostate,
yeah. And what's the problem with that?
they have a lot of complications.
Yeah, such as,
I know, what is it, erectile dysfunction is one of the main
uh-huh,
factors of removal of a large portion of it. You can also have urinary incontinence, fistula formation, and other stuff.
yeah. So just from the biopsy alone, you can develop like hematuria, you can develop prostatitis. But then, if you identify a prostate cancer, then you're kind of obligated to do something about it. So even if it's a prostate cancer that was never really going to do anything in particular, you might end up doing a prostatectomy or implant like radiation beads to treat the cancer. And the treatment of the prostate cancer actually can have numerous complications, like you mentioned. The erectile dysfunction is probably the biggest one that the patient population cares about, but there can be other things that happen as well. And it doesn't necessarily prevent them from developing, metastatic disease and things like that. So we don't know that screening with with PSA actually leads to clinical benefits, like reduction in morbidity and mortality. So it's a tough one. I mean, things are evolving. There's actually kind of a fairly good prostate MRI that can be done now to kind of be a step before you get a biopsy, because it can actually correlate pretty well with the Gleason score that you get on the biopsy. So if it looks fairly unremarkable, then you can actually, forego a biopsy. But I think until we get better recommendations, it's still going to be kind of a case-by-case basis. Okay. So some of the grade D recommendations, so again, the risks of screening actually outweigh the benefits, are screening for pancreatic, ovarian, and testicular cancer with getting tumor markers. So like, getting like a CA 19-9 or a CEA or what is it, the CA 125, yeah, for ovarian cancer, and then screening for thyroid cancer with periodic ultrasound. So you should not do this in the general population because there's very high false positive rates with these tests, and so you could definitely cause harm by doing other diagnostic testing such as biopsies and things. So right now that's kind of where the USPSTF stands on those cancers. And then there's basically insufficient information to recommend skin cancer screening or oral cancer screening or bladder cancer screening with UAs for like hematuria. So I did primary care for like 8 years before I came here. And if I had somebody who was like super fair with like white blonde hair, so basically like all the kids who go to school with my daughter at Savannah Country Day, I would recommend skin cancer screening, or at least like look over their skin for abnormal moles. But it wasn't really evidence-based. I just did it because I felt like I should. So all these kind of just are, hopefully we'll get more information in the future. So that's cancer screening. You guys have questions at all? Any cancers that you didn't see up there that you had questions about, or things you've heard? Nope. Okay. So one of the things that always kind of like makes the hair on my back, hair on the back of my neck raise up is when the residents will be in clinic precepting with me, and they'll be like, okay, so we'll get some routine labs. And so my goal for you guys to take away from this is there are no such thing as routine labs. There's, screening labs, and there's, diagnostic labs and things like that, but there's no such thing as routine labs. I'm sure you guys have probably all gone to a primary care doctor where they're like, oh yeah, I'll just get a CBC, CMP, TSH, UA. I inherited a bunch of patients from somebody who was retiring and had a different way of practicing, and so I had patients who were irate. They're like, where's my yearly EKG and stress test? And I'm like, so that's not happening anymore. I hope you don't mind, but this is why. So if you can take anything from this is to never say that again. So some of the labs that are recommended for screening according to the USPSTF are basically shown here. So it is actually recommended to screen at least once for hepatitis C and HIV in all adults. They kind of specified to age 65 for HIV, but I feel like that's like ageist because older people can still have fun. But the Hep C recommendation is relatively new. Like, we used to only recommend it in high-risk populations and in baby boomers because of the high rate in those populations. But now it's become so easily treated with a lot of the antiviral medications that we have available that it's actually recommended to screen all people once. And the HCA is actually doing this research project where they are actually having all patients who come through the ED get screened for hepatitis C and HIV unless they opt out. Because apparently in Georgia, you have to opt in for routine screening for HIV at least. And so we got a special exception to be able to have an opt-out screen. Do you guys know what that means? Opt-in versus opt-out.
You're gonna get it unless you specifically say that.
Yeah, so like before, like you had to ask for permission for it, and now you can basically say, I'm gonna do it unless you really don't want me to. And because that actually increases rates of screening. So that's for hepatitis C and HIV. Diabetes screening, again, everybody's going to have a different recommendation. So the American Diabetes Association and the American Academy of Clinical Endocrinology actually have different screening recommendations. But according to the USPSTF, the best evidence is to start screening at age 40 if a patient's overweight or obese. And so we'll talk about the ADA recommendations when we do our diabetes lecture in a little bit. Gonorrhea and chlamydia is recommended in all sexually active women under 24. And then cholesterol screening is recommended between 40 and 75 to calculate their 10-year ASCVD risk. We'll talk about hyperlipidemia later today, actually, so I won't get too much into it. So, I think probably most of you guys are in your 20s, but I bet you have all had your cholesterol checked, but it's not really necessary. I mean, again, this is like routine, so if you have like a significant family history or something like that, that's a different story. But in the general population, try to avoid ordering tests that are not needed. What is actually not recommended that either has evidence against it or insufficient evidence are getting a screening EKG to evaluate for coronary artery disease or arrhythmias, getting a carotid ultrasound to identify carotid stenosis to reduce their risk of stroke, getting a urinalysis to screen for, like I mentioned before, bladder cancer or also chronic kidney disease, and and getting herpes serology. I'm sure you guys have been kind of counseled ad nauseum about why we don't get herpes antibodies on patients during your OB rotations, right? No? So it just basically shows like antibodies, but it doesn't correspond to actual herpes disease. So when a patient asks for a herpes blood test, be like, no. If you ever have anything pop up, I can do a viral culture of it, but I'm not gonna do that because even if basically more than 2/3 of the population's been exposed to HSV, and that doesn't mean that you're actually going to develop clinical herpes. And then insufficient evidence is basically screening for peripheral artery disease with an ABI, getting a high resolution CRP. What would we use that for? Inflammation of So basically, this is kind of a surrogate marker for coronary artery disease. It is useful in some situations, but definitely not in the general population. Coronary calcium score, again, in the general population to screen for coronary artery disease, getting a sleep study for sleep apnea in the absence of symptoms. That's screening. If someone has symptoms of sleep apnea, you're doing a diagnostic test, so this is not screening. Doing celiac disease screening in the asymptomatic patient, getting a TSH to screen for thyroid dysfunction, and doing vision or hearing screening. So, I mean, a lot of people get vision and hearing tests, but it's like if they don't have any complaints, you don't necessarily need to do that. So, so some of the other screening tests that didn't really fall into like labs that I wanted to go over were screening for osteoporosis, because that comes up a lot. The USPSTF has a kind of strange recommendation, but basically they recommend getting a DEXA scan in women 65 years and older, or if you're younger or male and have a risk equivalent to a 65-year-old white lady. That's like literally what it is. So have you guys heard of the WHO's FRAX tool? Basically, you can use that with or without a DEXA score to calculate somebody's 10-year risk of an osteoporotic fracture and hip fracture. And so if you think that somebody has risk factors for osteoporosis and you want to see if they need to get a DEXA scan, then you can kind of use that to justify doing that as a screening test. But generally, women 65 years and older should have it. And then the other thing too is screening for abdominal aortic aneurysm. So it's actually recommended to do a one-time ultrasound of the abdomen in men between 65 and 75 if they've ever smoked. And it's an individual consideration for men who have never smoked. So if they've never smoked and they have a family history of a ruptured AAA or something like that, you might consider doing it, but in most cases you'll only recommend doing it in patients who have smoked between those ages. Okay, so just quickly, because I did take a long time trying to figure out how to get this recorded, and hopefully this is working out okay. But basically, you guys will probably do some Medicare visits when you are on your outpatient part of the rotation. And basically, Medicare has like a whole laundry list of things that you're supposed to go over at their annual visit in order to kind of optimize their healthy living. And so just to kind of quickly go over, like they want you to kind of address their activities of daily living and their independent activities of daily living to make sure that they're thriving, or to identify opportunities to help them or get them resources at home if they're unable to do that. Medication adherence, food security, sexual health, safety, pain, depression screening, substance abuse screening, fall risk, and then activity and nutrition review. You also should do a cognitive screen, which we'll talk about. We have a lecture later in the block on dementia and delirium and some of the tools that we have to use for that. And then kind of just doing general history, like family, medical history, medication review, immunizations. Make sure that you're aware of like who their other providers are. And they actually recommend doing a vision test at that time too, and then just get their vital signs. And so I just wanted to also talk about the immunization schedule. This is actually the most recent ACIP. Actually, I always forget what ACIP stands for, but something from the CDC about vaccinations. This is the most recent adult schedule, and we'll kind of talk about the most important ones kind of going forward. So when you guys think about vaccines for adults, what do you guys think about?
Influenza.
Okay, influenza, and who gets those?
Everyone, especially elderly.
Yeah, so everybody. And in the elderly population, do we do anything special for them?
They did a different. For,
So they get a higher dose, actually. So basically it has like 4 times the amount of the antigen, and it's supposed to hopefully help them mount a more robust response than if we gave them the regular dose of the flu shot. The influenza vaccine is actually not super effective, and it varies from year to year. And so at best, it actually maybe has like 50% protection of flu, but that kind of like calls upon herd immunity. So like the more healthy people that you vaccinate and who will avoid getting sick, the better to prevent them from exposing their more at-risk like relatives and friends.
when you say elderly, are you talking like over 65?
Yeah, over 65, we do the high dose flu is what's recommended. And so like when I was doing primary care, I had like mixed panel of patients, but I had a lot of patients who were like younger, and they'd be like, yeah, I don't want to get the flu shot. I never really get the flu. It's not a big deal. And I'm like, well, are you going to visit your grandma for Christmas or Thanksgiving? And they're like, yeah. And I'm like, wouldn't you feel bad if you gave her the flu and she died? So that was kind of like my like guilt trip of getting them to do it. So that's flu. What other vaccines do you guys think about? Pneumococcal. There's a whole slide on that because it can get pretty complicated. Tdap, okay. And who do we give Tdap to?
I know they get it in adolescence and then once every 10 years.
Uh-huh. Okay. And what's Tdap stand for?
Tetanus, diphtheria, and pertussis.
Yeah, exactly. And so do you have to give a Tdap every year, every 10 years? Yeah, so basically we recommend giving the TD booster every 10 years, and at least once in adulthood, you should have a Tdap to cover you for pertussis, because you do have waning immunity from that over time, and there have been a lot of outbreaks of pertussis. And you guys probably know, like, all people who are going to be parents need to get a Tdap every single time they have a kid. So I don't know if that's super evidence-based, but they require it. Any other ones? Okay, so let's kind of jump right into these. So basically for the general population, the ones that we should do are the yearly influenza. Like I mentioned, getting a TD every 10 years with at least one Tdap as an adult. The Shingrix, you guys know what that's for? Shingles, okay, and we'll talk about that in a second, which is 2 doses, and that's recommended after age 50. Or I guess I should say it's approved after age 50. Is it recommended now? I actually don't think that it is. Oh, it actually is recommended now. Okay. Human papilloma virus, we give 3 doses of that, ideally before age 26, but it's actually now approved up to age 45, so it's kind of an individual consideration for that. So you can see here, like the on the slide, it's like kind of in that like light blue color because it's like optional, but generally you want to do it before 26. And then pneumococcal actually has new recommendations for it. Some special circumstances All live vaccines are contraindicated in immunocompromised patients. Do you guys know what constitutes immunocompromise?
Yeah, long-term course of steroids, could have HIV/AIDS.
Okay, yeah, so if they're on long-term steroids, so basically equivalent of like 20 milligrams a day of prednisone, they are relatively immunocompromised. HIV, if you have a CD4 count of less than 200, that's considered immunocompromised. So you can get a live vaccine if you have a CD4 count of like 600, but just happen to have HIV. And then if they're on like chemotherapy or some of the other like immunomodulating drugs that we have for some autoimmune conditions. And so the live vaccines are the MMR, obviously, varicella vaccine, Zostavax, which is the old shingles vaccine that we used to give. It actually didn't work that well anyway. And then the live influenza vaccine. So the mnemonic that I like to use for the pneumococcal vaccines is basically pneumovax to the max. So we have the two pneumococcal vaccines. We have Pneumovax, which is the polysaccharide vaccine with against 23 strains of strep pneumo. And then we have Prevnar, which is the conjugated vaccine against 13 strains. So Prevnar actually confers better immunity against those 13 strains than the polysaccharide vaccine. But generally, I always think of Pneumovax to the max because it's the higher number. So I always think of the max from that. And then you end up giving it a lot, and you also give it to more people. So basically, you'll give it to everybody once they hit 65, like I kind of mentioned here before. And then if they have any sort of chronic condition, or they smoke or abuse alcohol, they should get it at least once before they turn 65. So if they have like diabetes, if they have coronary artery disease or heart disease, if they have COPD, other chronic lung disease, chronic liver disease, like if you really think that they might need it, they probably do, but it's always good to look it up. And then if they are immunocompromised or have CKD, they actually have to get a second dose 5 years later before they turn 65. So if they're like 50, they should get one at 50, one at 55, and then one again at 65. So that's why I always think of it as like to the max. Now, Prevnar actually, they changed the recommendations very recently, I think only like a month ago. And it used to be recommended for all patients once they turn 65, and then earlier if they have cochlear implant, CSF leak, or they're immunocompromised. But now it's actually optional in the patients above 65, and it is still recommended for patients who have cochlear implant, CSF leak, or are immunocompromised. So that's why here it's kind of in that like light blue area because it is optional now. You guys have questions about pneumococcal? Okay. Hep A vaccine is recommended for anyone who has chronic liver disease or in men who have sex with men. And then hepatitis B vaccine is recommended for anybody with chronic liver disease, end-stage renal disease prior to dialysis, healthcare workers, and close contacts of those infected, and then in patients with diabetes. Actually, that's all I have for you guys. So, do you guys have any questions about screening, immunizations, labs?
Do you think the screening with ultrasounds are going to change in the future when ultrasounds become more available?
Possibly, because I do think that like point of care ultrasound, or POCUS, I guess it's called now, is being more widely part of the medical education curriculum. And so I think point of care ultrasound is definitely going to be a helpful tool in the diagnosing tests. Right now, it's still not considered to be like good enough to use in placement of like a formal ultrasound, but I definitely could see in the future where it might become that. So that's a very vague response to say maybe. All right. right, cool.
Did you say that we have another lecture today?
Yeah, so you guys will have noon conference. I think Dr. Hannah's giving it. He's a really good lecturer. And then after that, I'm not sure where Tennille scheduled it, but we're gonna have another lecture at 1:45. So like basically make your way, it'll probably be over here. Make your way over here and we'll do that lecture. All right, cool. Thanks, guys.